All right, friends. So now we are going to do a comparison of one topic, and you people would understand that how we have to extract the common information. We are going to do the diabetes and pregnancy management from preconception to the postnatal period. We do have a wonderful, nice guideline, which we do in the European board and we do for the MRCOG as well. And we have an Irish diabetes guideline as well. Now, the entire Irish diabetes guideline, that is similar to that of the NICE guideline, except certain values which are typical used in Ireland. The values are different, and I'll make you understand that where we have to deviate from the NICE guideline. Now, we've got two types of students. Firstly, who have done NICE guidelines so many times for their exams, and the others who are reading for the first time. The ones who are reading for the first time will do only the Irish tables. The ones who have been revising the NICE recommendations for so long, they will just put a stick on their own notes of the NICE guideline and see the differences only. Do you guys understand this? Yes, you will open up your NICE diabetes notes and you will put the stick-ons on the side, Irish recommendations 1, 2, 3, 4, 5. Your job would be done. Am I clear about the outline that how you have to utilize? Not from zero. Already you have made around 50 to 60% of the effort, and you're just going to add on to that. All right? Very well done. So the NICE guideline says that preconceptional planning is very important. Now I need your attention, please, because the gist which I want to give you today, that would go with you guys till March 2023. And you have to be very, very clear that what we have to prepare, how we have to prepare, and how we have to be successful in one go. Okay. Now, in the preconceptional period, both the Irish and both the NICE recommendation for RCOG and RCPI is that we tell the women that they need to have a very good control on their glucose levels just to be in the best shape of health to get pregnant. Therefore, in the preconceptional period, we check their glycosylated hemoglobin HbA1c levels to check that how far the levels are within the normal limit. This holds true for the Irish recommendation and for the RCOG UK recommendations as well. We have to tell them that if at all they are having the BMI above 27 kilogram per meter square, they are suggested to lose weight, and the NICE guideline says that these women are advised for having the folic acid 5 milligram per day until 12 weeks. Here, they say 5 milligram per day until 12 weeks. However, they do not tell about the preconceptional. So I will open up my notes. I will see that what does the Irish guideline say? And I will put one stick on here because the Irish guideline that clearly says that high dose folic acid 5 milligram is done, but at least 3 months prior and 12 weeks and the first trimester, that is 12 weeks gestational age. Do you guys understand? It's a minor point that the Irish recommendation is very clear that at least 3 months prior and 3 months after getting pregnant. So just add this one point. I would tell you guys to open up your notes and you'll just add this one point 3 months prior and 3 months after getting pregnant. A fasting plasma glucose levels in the preconceptional period as per the NICE are 5 to 7 and the plasma glucose levels before meals are 4 to 7. Please forget this for the exam RCPI. The values in the preconceptional period, we will again change from that of the NICE and we'll come to the recommendations. The Irish recommendations state that capillary glucose targets are recommended in the preconceptional period, fasting beer 3.5 to 5 millimoles per liter and 1 hour postprandial less than 7 millimole per liter. Am I clear? Fasting being 3.5 to 5 millimole per liter and 1 hour postprandial less than 7 millimole per liter. Very well done. So you don't have to worry. Everything in the preconceptional is same except this. So put a stick on or take another colored marker and write on the side of your recommendations of NICE that this is the change as compared to the preconceptional recommendations. HbA1c is the same in Irish and NICE, less than 6.5 or 48 millimole per mole is taken to be the aim, where we allow the pregnant women that yes, preconceptional women, that yes, she can become pregnant, right? And we tell her that lesser is the HbA1c, better is the chance that we have a reduction in the congenital malformations in the baby. Both the NICE guideline and the Irish guideline, both of them, they say that when HbA1c is more than 10%, I repeat, above 86 millimole per mole, we tell them that the chances of having the congenital abnormalities are very, very high. So they have a consensus on the HbA1c values. Both of the guidelines, they recommend metformin as an adjunct or an alternative to insulin in the preconceptional period or during the pregnancy. So we have a consensus on the medications and the safety of the medications in both the guidelines for both the exams. We have a consensus on the retinal and the renal assessment as well. The retinal assessment, if it is being done in the preconceptional time period within 6 months, so that means it is fine. And if there's no diabetic retinopathy, so the cutoff is in the last 6 months, it should be done as the check for the retinal assessment for any patient who is in the preconceptional time period. And then annually, it has to be done if the patient is fine, otherwise a no diabetic retinopathy is there. Renal assessment holds the same in both the recommendation that we have to do for a patient in the preconceptional time period, serum creatinine, urine albumin creatinine ratio, the glomerular filtration rate, and if any of them goes into the abnormal value, we refer to the nephrologist, and that should be considered prior to she gets pregnant. That is, before discontinuing contraception, so that we know that what is her renal assessment by the expert physician. Please remember, both the guidelines tell us that in the pregnancy, we would do the serum creatinine, we would do the urinary albumin creatinine ratio. However, in the antenatal period, we skip the estimated glomerular filtration rate because of inappropriate value, because of the increased vascular and the blood supply to the kidneys. Therefore, in the antenatal time period, 2 tests would be done, serum creatinine and urinary albumin creatinine ratio. Please keep a note for a single-based answer. If she comes in the preconceptional time period, we will actually select 3 investigations. When she is in the antenatal time period, it would be 2 investigations that would be chosen, excluding the GFR. Now I need your attention. The risk assessment for gestational diabetes, we have got 5 risk factors where we call those patients for the oral glucose tolerance test. Why? Because they are high risk. That includes their BMI above 30 kilogram per meter square, a macrosomic baby previously weighing 4.5 kilogram or above, a previous gestational diabetes, a family history of diabetes, and a minority ethnic family origin with high prevalence of diabetes as well. But we've got a wonderful guideline, Irish guideline number 2, which has an obesity in detail, and they give us multiple factors where 2-hour 75-gram oral glucose tolerance test is being done. And they tell us in the Irish recommendation, if the patient has got BMI more than 30, please remember the maternal age is not given in the NICE guideline. But if maternal age is more than 40, we do perform OGTT as per Irish recommendation. If previous unexplained perinatal death was there, we do perform OGTT in this pregnancy. With current glucosuria, a patient who is taking long-term steroids with previous macrosomic baby is the same recommendation. When the patient has got a polycystic ovarian syndrome, she's got complication in the existing pregnancy, and if she belongs to the high-risk ethnic group. So we have certain additional points for the indication of OGTT. Again, when you open up your NICE recommendations, you can simply write on the side that these are additional, like maternal age more than 40, right? Previous unexplained perinatal death, like polycystic ovarian syndrome. And with macrosomia current, polyhydramnios in the current pregnancy, we are going to do OGTT to confirm that this patient has got diabetes or not. Am I clear? Am I clear? 5 points you already know. So we are adding on to that. So we know that Irish recommendations are higher than that. Javaya Somro, am I clear? Mehreen, Faridi, am I clear? Talha, the indications which are more for the OGTT in the Irish setup, are you people clear about this? Yes? Okay, perfect. Thank you very much, Vifak. Thank you, Faridi. Thank you, Zo, my dear. Now, glucosuria, same if it's 2+ or above on one occasion or 1+ or above on 2 occasions, we have to confirm that it is gestational diabetes or not. That is common in both the NICE and the Irish guideline as well. Coming to a second big difference. It was very easy for us to remember the oral glucose tolerance test, friends and family, for 5, 6, 7, 8, which we used to do in the RCOG exam. Please remember that there is no 5, 6, 7, 8 when it comes to OGTT in the Irish setup. The guideline says that the fasting 5.1 or more, if at 1 hour it's 10 millimole per liter more, 2 hours 8.5 millimole per liter. So these are the values to diagnose on 75-gram oral glucose tolerance test. Point noted, everyone? The OGTT values in diabetes are different for that of the confirmation which are being used in UK. Am I clear? Did you guys understand the difference, please? These values we would be remembering for our single best answer when it comes to the MRCPI written exam. All right. And even in the OSCE students, they said the same when it is a Viva question from the examiner. For MRCPI, the diagnostic values would be this. The management plan, fortunately, stays the same. We are going to give this patient, if fasting glucose is less, we would give a trial of diet and exercise and metformin if it doesn't work, and then insulin. Even one value above this level, Zo. Yes, a very valid question, even one value if it's above that. If at all the fasting glucose is 6 to 6.9, we consider immediate treatment. And if it's 7 and more, we offer immediate insulin treatment. Please ensure that you remember this for the single best answer. And the glibenclamide would be only for those women either who are not having a successful management plan with metformin, or they cannot take metformin, or they cannot tolerate or are having the contraindications to this medication. How many times do we check? For the type 1 diabetes, same monitoring as we had in the NICE, same as in the Irish, that we are having 7 checks. Very well done, Faridi. Very well done, my dear. Fasting, pre-meal, 1 hour post-meal, and bedtime. How much does it make? 1 is fasting, correct? Then 1 is 2 are pre-meal, pre-lunch and pre-dinner. 1 hour post-meal at 3, and 1 bedtime. So that makes a total of 7 checks. Am I clear? How did we make the 7 checks? Am I clear, friends, that how did we make Yasmin? Yes, how did we make 7 checks? Yes, 7 checks are clear? Perfect, Anam. So the other is type 2 diabetes. In type 2 diabetes, we have 1 fasting and 1 hour post-meal, so 3. So 1 plus 3 is going to be 4. 4 checks in the type 2 diabetes. Ensure if the type 2 diabetes or the gestational diabetes friends that is having multiple insulin administration. So my question to all of you is that if type 2 diabetes or the gestational diabetes is not on oral management and not a single agent is being used, multiple agent is being used for the diabetes control for insulin. Thank you, Mehreen. This calls for a very old information when I used to teach you nice guideline, Mehreen. Yes, type 2 diabetes and gestational diabetes on multiple daily insulin injection would be same as that of type 1. That is seven times we are going to check. Same as that of type 1 diabetes. Now coming to the pregnancy. The NICE guideline says that we advise the pregnant women with any form of diabetes to maintain their capillary plasma glucose below the levels of the target. Now, the NICE guideline says fasting 5.3, 1 hour, 7.8, 2 hours after meal, 6.4. I'm sorry again, but we have to forget this for our CPI. Because diabetes during pregnancy, our CPI says that pre-prandial and pre-bed would be 3.5 to 5. 1 hour post-prandial would be less than 7, and that's it, right? They say that the target capillary blood glucose levels and the HbA1c targets should be explained. Again, pre-prandial and the pre-bed less than 5, and 1 hour post-prandial will be less than 7. So now with the older, if anybody has remembered the older values, you people would forget that sitting in MRCPI and you would remember these values. Or if anybody is doing for the first time, would do these values for this exam. Am I clear? What's the basic difference? Did you guys understand, please? So far, yes? Everybody clear? The retinal assessment, thankfully, is the same, Seher, that we do at the first antenatal appointment. If it's been done in the last 3 months, we do not repeat. And again, we do that at 28 weeks. If the patient has got diabetic retinopathy, then we do that at 16 to 20 weeks, an additional retinal assessment. Same as the renal assessment would be within 3 months. If it's done, we don't repeat that. We have it after the booking and we check other than the glomerular filtration rate, we have the other investigations for which we check. Any patient who has a nephrotic range proteinuria, 5 grams per day, that would be an indication of thromboprophylaxis. When I will do the maternal medicine with you all, we will do the venous thromboembolism differences the same way as I'm doing the diabetes differences with you guys. Now, we perform an ultrasound in the diabetic mother for detecting the structural abnormalities. And also, we need to check the examination of the fetal heart at 20 weeks. If at all, the patients, they receive steroids, because steroids are hyperglycemic, we may give additional insulin. And both the guidelines, they have a consensus on this recommendation. Now comes a very important point, which I want you to register, because that's another basic difference after the investigation. We will do that. Yes, my dear. The gestational diabetes, if no complication is there, the NICE guideline says that 40 plus 6, we can deliver the patient by that time. Again, you have to ignore that for our CPI exam. The guideline says that the frequency of fetal monitoring should be increased if the pregnancy is allowed to progress beyond 40 weeks of gestation. And even if the patient has got excellent glycemic controls, adherence to the treatment, and absence of any compromise, women with diabetes may await spontaneous labor up to 39 to 40 weeks of gestation. So what we'll remember for our CPI is not 40 plus 6, 39 to 40 weeks of gestation. Similarly, the NICE guideline for the type 1 and the type 2 diabetes with no complications says that we may take them till 37 to 38 plus 6 and with complications earlier than 37. Again, we have to forget this because what we'll remember is that in the presence of the obstetric or diabetic complications, they say that should be considered at 38 weeks. What is the difference? The difference is that they say it is going to be earlier than 37 or till 37, but the Irish setup allows us, even with complication, till 38 weeks. We are talking about a known diabetic patient. Am I clear? Is this point noted, everyone? Everybody clear, please? The ones who are not active in the chat, I want all of you to be active. Yes, please tell me that is this point clear. Perfect. Very well done. Yes, everyone who is silent, please. I need everybody to be interactive and everybody to be active. That's perfect. Thank you. And if at all, we have to do Noor, elective cesarean section that is best performed at 39 weeks rather than 38 weeks gestation in the absence of the complication. So thank you, Namath. Happy to see you, my dear. Thank you very much. Thank you, Haifa. Very well done. Everybody, please be attentive. These points, if you learn today, you will just have to revise once again. The memory would be better. Just register these points, which are the differences. That's it. Thank you, Raga. Very well done, Saira. Ensure that you people understand that here it is going to be 39 to 40 when excellent glycemic control is there. Both, thank you very much, Talha. Well done. Talha, both in GDM and both in type 1, type 2 diabetes, they say if the glycemic control is fine, let them go to 39 to 40 weeks. And if the complications are there, then it would be 38 weeks. Anesthesia, for general anesthesia, both of the guidelines, they say that every 30 minutes, we are going to have a check for the glucose control, and 4 to 7 is a consensus, luckily, both in the Irish guideline and the NICE guideline, that we are going to keep the control in 4 to 7 millimole per liter. Both have the same consensus. The Irish and the NICE recommendation, both are the same, 4 to 7 millimole per liter in the labor and delivery. So intrapartum values are luckily the same. During the vaginal delivery, they say 4 to 7. And they clearly say that during an anesthesia, they do not say 30 minutes. What they say is that it won't be hourly. During general anesthesia, frequently we have to monitor the blood glucose levels. RCOG says that we have to do every 30 minutes. RCPI says hourly is in labor. Here we have to do frequent. So we take the recommendation from the NICE because here we don't have specific timings. So every 30 minutes under the general anesthesia, it would be taken. Thank you very much. Half an hour, Noor. In labor, it would be 1 hour. That is 60 minutes. In general anesthesia, it would be 30 minutes. Okay? Now the babies, we are concerned about the neonatal care. Why, Noor Mohammed? Because we expect certain complications, babies born to the diabetic mothers, like polycythemia, hyperbilirubinemia, hypocalcemia, hypomagnesemia, and we are concerned about the congenital cardiac problems in the baby as well. So we admit those neonates who have the signs, the clinical signs of hypoglycemia, respiratory distress, neonatal encephalopathy, polycythemia, and they require additional management. They're getting hypoglycemic. So the preterm babies, both the guidelines, they say that they require additional care. And to prevent hypoglycemia, we should give them written policy. And we should understand that they should have frequent feeding as well. Here comes another difference, please. Open up your notebooks. The capillary plasma glucose values below 2 millimole per liter is taken to be in NICE as hypoglycemia. And they say that early feeding within 30 minutes and every 2 to 3 hours, we start feeding in 30 minutes and every 2 to 3 hours, we should have frequent feeding. So in Irish guideline, they say that hypoglycemia is when the blood glucose is less than 2.6. Difference noted? NICE says the neonate is hypoglycemia in less than 2. The Irish recommendations say that the baby is hypoglycemic less than 2.6. Am I clear about this tiny difference, please? Point noted, everyone? Is this point noted, everyone? These are slight points, but if you remember these, you would have such a good grip over the guidelines. Nobody can beat you in a single best answer if you people read with comparison. The postnatal care, they say, immediately you might have to reduce the dose of the insulin. Why? Because the chances of the requirement of the insulin are reduced. So they say that postpartum insulin regimen, that should be like, very good, Hua, my girl, very well done, like pre-pregnancy she was taking. And they say postpartum also, we should maintain 4 to 7. This is not given in our COG. Postpartum RCPI says 4 to 7 maintained, same as that of labor. Now again comes a big difference. If we recall our NICE guideline, you people remember that they told us to do fasting plasma glucose at 6 weeks to be sure that it's not a GDM. And if it's not done, they say at 13 weeks, we can do HbA1c. Do you guys remember? What investigation? Everyone, please, I need your attention here. All the neurons towards my side, please. Do you guys remember that what is that investigation which is done postpartum to check that the patient had GDM and now she's better? What is that investigation in the NICE guideline? Fasting, very good, Faridi, and HbA1c NIMC at 13 weeks, very good. And they specifically say one thing, that this investigation should not be done postpartum. Do you guys remember? What is that investigation they say? Which should not be done postpartum. There is a specific investigation they are saying that you should not do postpartum. It should not be routinely mentioned. So please forget this recommendation when you are sitting, Anita, in RCPI. Because RCPI clearly says that a 75-gram World Health Organization criteria for the non-pregnant population should be performed at 6 weeks postpartum and then annually. This is a very big difference. RCOG says do fasting, sugar levels, and HbA1c. RCPI says, and RCOG says do not perform routinely OGTT. RCPI says for all patients who have given birth who had GDM would undergo OGTT at 6 weeks postpartum and then annually as well if it's normal. Did you guys note this point? Did you guys note this point? If these differences you people note down, nothing would be a difficulty for you guys. Am I clear about this oral glucose tolerance test postpartum? We never select that when we actually talk about the RCOG recommendations in the postpartum period. And we always select that when it comes to the postpartum Irish question. It's a confirmed single best answer. It is your recall question of all exams of September 2022, March 2022. They ask you that the patient had GDM, investigation to confirm and to see and assess her state. You people will select 6 weeks postpartum oral glucose tolerance test, right? If anybody has not read this guideline, they would go with fasting or HbA1c as per the RCOG recommendations. Because RCOG clearly says not to do that in routine. RCPI says, please perform OGTT at 6 weeks. Could I make myself clear, please? Are you guys following me for this, please? Yeah? So the postpartum, we have got WHO levels of diabetes, impaired glucose tolerance test, and impaired fasting glucose. This is what we need to remember. At 6 weeks postpartum, we would have her World Health Organization recommendations, please. All right. Now, if I tell you guys, we have done the detailed guideline, all the NICE and the recommendations of Irish. If I give you 3 slides and I tell you that if you do these 3 slides, nothing would be a trouble, and you attach on your same notes, your topic would be done. As students were saying that at the end of the day, they used to do only those flashcards, which I provide in the session. The Irish diabetes type 1, the glucose target in the preconceptional period, the blood glucose levels during the pregnancy, during labor, during C-section, during general anesthesia, and postnatal as well. The Irish guideline recommendations type 2 diabetes, glucose target in preconceptional period, during pregnancy, during labor and delivery, cesarean section, and postnatal. Gestational diabetes, 75-gram OGTT levels, diagnosis on the basis of fasting, 1 hour, 2 hours, the targets during pregnancy that have to be met pre-prandial and pre-bed, 1 hour post-prandial, during labor and delivery, during cesarean section, and at 6 weeks, we have to do 75-gram OGTT, then yearly thereafter. Did you guys understand? This is the gist which was in different recommendations in different part of the guidelines, and only these are the differences of the Irish guideline and the NICE guideline. Rest, everything is similar. Every part is similar. If we take out the values and we learn these values, nothing would be a trouble for you guys. Because at the end of the day, this is what, if you reproduce, your job is done and your topic is completely covered.